We're going to be going to the second lecture of the day. It's going to be on pulmonary embolism. Very interesting topic that we all need to know about. As anesthesiologists, even as internists that work in the medical ward, patients are predisposed to having either a deviant thrombosis that can progress into pulmonary embolism. And the mechanism by which this happens, we need to at the same time understand the way to actually treat this patient as well. Now, without much ado, I'm going to be introducing to us one of the experts in this field to give us the presentation. With due honor and respect, I introduce Dr. Tharwat Aissa. Dr. Aissa completed his master's in anesthesia and MD in anesthesia, a master's in 2006 and MD of anesthesia in 2015. And he has a diploma from the European College of Intensive Care Medicine in 2012. He equally obtained the European Diploma of Anesthesia and Intensive Care in 2018. He has worked as a consultant in anesthesia and intensive care in Egypt. He was a former associate consultant at the intensive care medicine in King Abdullah Medical Center in Makkah. He has currently working at the Our Lady of Lourdes Hospital in Ireland. Wow, amazing. One of the places I started my own training as well. And is highly interested in ICU research, and he is a very, very published man. He has so many publications, peer-reviewed publication. With due honor and respect, I present to you Dr. Tharwat Aissa to speak to us about pulmonary embolism updates. Thank you so much, Dr. Aissa. The floor is yours.
Thank you very much, Dr. TOLU, for your nice introduction. And I would like to thank Dr. Mahdi and the rest of the organizing committee for having me tonight. And I'm going to talk about the pulmonary embolism updates and an outline to the topic today. I'm going to touch the epidemiology, and we will talk in details about the diagnosis, prognosis, and of course the available management lines according to the current evidence and guidelines. And of course, we cannot talk about venous thromboembolism without talking about COVID-19 related venous thromboembolism. And if we have a good time, we can talk about algorithmic approach for the management. As you can see here, guys, in this picture, this is an autopsy specimen for the lungs and the pulmonary artery, which is filled with a thrombus inside. And as you can see, and both lungs are infarcted. Of course, we don't want our patients to be like this. So in terms of epidemiology, in the US, we have more than 530,000 of cases of symptomatic pulmonary embolism per year. And the mortality is high, as you can see, up to 300,000 per year. And 54% of these patients pass undetected, unfortunately. And in some recent studies released about COVID-19 related thromboembolism, the incidence up to 24%. And you can see here in this figure that the prevalence is going to be doubled by 2050. So it is going to be a journey among the different available guidelines, American College of Chest Physicians guidelines, and American Heart Association guidelines, latest version of European Society of Cardiology guidelines 2019, and Anticoagulation Forum as well. So starting with the definitions and why we should know the definitions for each type of pulmonary embolism. It is very crucial because it has its clinical implication for further risk stratification of such patients and subsequently the management. So what is the massive pulmonary embolism? What do we mean by massive pulmonary embolism? That is a patient who has hemodynamic instability, and it is determined in the guidelines by systolic blood pressure below 90, or if the patient is hypertensive and he has a reduction in the blood pressure for 40 millimeter of mercury or more from the baseline, plus signs or symptoms of hypoperfusion. This is what we are calling the patient has obstructive shock due to pulmonary embolism. This is the patient we are calling him, he has massive pulmonary embolism or high risk pulmonary embolism. What is about the submassive pulmonary embolism? Those kinds of patients are hemodynamically stable. So the systolic blood pressure is more than 90 millimeter of mercury, but they have an evidence of right ventricular dysfunction in echo. And those kinds of patients are further risk stratified more into high risk and low risk, and we are going to talk about this in a couple of minutes. So the last one is the low risk pulmonary embolism or the non-massive pulmonary embolism. That is the patient who is hemodynamically stable and he has no RV dysfunction and normal biomarkers, normal troponin and BNP. And this is, of course, a patient out of our scope tonight. So in terms of the pathophysiology of pulmonary embolism, as you can see here in these figures, that a relationship between the mean pulmonary artery pressure and the flow, which is the right ventricular cardiac output. And this slope represents the pulmonary vascular resistance, actually. And the steeper the slope of this curve, the steeper the slope, the higher the pulmonary vascular resistance. And of course, you can see the more workload on the RV. So the RV is more suffering here with increased resistance to push the same volume of the cardiac output. So in this diagram, there is a cascade of events will happen due to the pulmonary embolism, the major pulmonary embolism or the obstruction in the pulmonary vessels. Pressure overload on the RV with subsequent increase in the wall tension, and of course the oxygen demand will increase, and this leads to right ventricular decompensation and decreased RV stroke volume or RV overload. This will lead to RV overload and septal shift to the left side, which will subsequently decrease the left ventricular end diastolic volume, and finally low cardiac output, shock state, more hypotension to the patient, and the coronary perfusion pressure will decrease. The RV will be more compromised, and there is some reports that the RV will have subendocardial infarcts. And this is the reason why you will find a troponin leak in such patients, in addition to elevations of the BNP and pro-BNP. And it is a vicious circle. You should cut this circle by using any kind of reperfusion to your patient. You can see here in this study that a comparison between the patients who has underlying cardiopulmonary disease versus the patients who has a good cardiopulmonary reserve in terms of angiographic obstruction or pulmonary artery mean pressure will be higher, of course, the cardiac index will be much lower, and the total pulmonary resistance will be much affected in such patients. So the outcome will depend on the burden of the embolus and the severity of the pulmonary embolism and the underlying cardiopulmonary status and RV dysfunction, of course. If you have a patient who has massive BE obstructive shock, the mortality approaches 30%. If the patient has developed the cardiac arrest because of the pulmonary embolism, the mortality is much higher, up to 70%. Risk factors, of course, it is well known, Virchow triad of the stasis, endothelial injury, and hypercoagulability. And we have inherited hypercoagulability state or thrombophilia, that's protein C deficiency, protein S deficiency, factor V laden, and also acquired the thrombophilia state due to immobilization of the patient for more than 48 hours, surgery, malignancy, some hormonal therapy, and surgery, specifically the pelvic surgery and neurosurgeries, and also some other factors of acquired thrombophilia like morbid obesity and heparin therapy even. In terms of diagnosis and the prognosis, you guys know that the presentation of pulmonary embolism is very variable, and the manifestations varies from dyspnea in 79% of patients, and tachypnea in 57% of patients, tachycardia, chest pain. And for the gas exchange, you should know that not every patient with pulmonary embolism will develop hypoxemia. In 32% of patients will have a PO2 of more than 80 millimeter of mercury. And the most of the patients will hyperventilate to PCO2 below 40, that's 81% of the patients, despite you have increased the space in such patients. Third of the patients will have a normal alveolar arterial oxygen gradient, and the evidence behind that is a PIOBID and DIOBID trial. These are the largest trials studied the manifestations, presentation, and the investigations for pulmonary embolism. You can find some non-specific to the pulmonary embolism, but sometimes you can find these ECG changes like deep S in lead 1, Q3, and T3 triad. You might find also sinus tachycardia, right axis deviation, right bundle branch block. This is due to pressure overload or right ventricular strain. Also, one of the common atrial tachycardias in patients with pulmonary embolism is atrial fibrillation. Chest X-ray studied also in the PIOBID and DIOBID trials, and they found that normal chest X-ray in the range of 16 to 34% of patients will find the X-rays totally normal, but you might find some clues for the pulmonary embolism like atelectasis or consolidation, which represent lung infarction, or you can find some pleural effusion. But still the gold standard for diagnosing pulmonary embolism in terms of the imaging studies is the CT pulmonary angiogram. And it is better to correlate the CT pulmonary angio findings with the clinical probability of the pulmonary embolism. You can see the positive predictive value of the CT pulmonary angio approaching 96% if the patient has high clinical probability of pulmonary embolism. And the negative predictive value to rule out pulmonary embolism in a patient who has low clinical probability is 96%. So in the guidelines, you are safe to reject the diagnosis of pulmonary embolism without further testing if the CT pulmonary angio is normal and you have low or even intermediate clinical probability for pulmonary embolism. And this is a high level of evidence. And also you are safe to accept the diagnosis of pulmonary embolism if the CT pulmonary angio showing the filling defects and you have intermediate or high clinical probability. In some situations, there is discordance between the clinical probability or your clinical judgment and the testing, which is the CT pulmonary angio. This is the patient who will need further testing. VQ scanning also studied in the PIOBID trial, and it is safe to roll in or to roll out pulmonary embolism with high probability scanning if correlated with clinical probability score. So if it is high clinical probability and high probability scanning, it is approaching 96%, while it's 4% if it is low clinical probability. So we are talking about clinical probability. So you guys should know that any patient admitted with pulmonary embolism, either you are consulted to see him in the ED, on the ward, or admitted to your ICU, you should do clinical probability for the patient before asking for any test, because all the results are correlated to the clinical probability. Moreover, you should also risk stratify your patient in order to categorize my patient is high risk BE or massive BE, or he is intermediate risk BE or low risk BE, because the management will depend on this, and also the disposition of the patient to the ward or to the ICU will depend on the risk stratification. So the commonly used scores and the commonly validated scores in the guidelines is the Wells score or modified Wells score and Geneva score. Don't bother yourself to memorize these items, which is clinical signs, symptoms of DVT. Pulmonary embolism is in the top of your differential diagnosis, or the most likely, or tachycardia, heart rate more than 100, immobilization at least for 3 days, or history of BE or DVT or cancer. And you can, because it is available everywhere in the applications, MedCalc, or you just Google it, you will find it and you can calculate bedside within a few seconds. If the patient is having a score of more than 6, this is high probability. If it is below 2, this is low probability. Between is intermediate. Or in the modified score, you can see that if the score is more than 4, BE is likely, or 4 or below, the BE is unlikely. Of course, Geneva score also is well mentioned, and you can use one of them. For the risk stratification, this is mentioned in the guidelines, the simplified pulmonary embolism severity index, and it correlates the 30-day mortality for pulmonary embolism with this score. And this paper is talking about the simplification of the pulmonary embolism severity index for prognostication of such patients. They only used 6 items of the score, which is age above 80 and history of cancer, COPD, tachycardia of 110 or more, blood pressure below 100, or saturation below 90%. If you have one of this you can say simplified pulmonary embolism severity index of 1. This is correlated with mortality, 30-day mortality of almost 11%. If it is 0, the mortality is down to 1%. Biomarkers, as we have mentioned earlier in the pathophysiology, that there is troponin leak in the patient who has RV dysfunction, RV strain, and also due to volume overload and the stretch of the right ventricular wall, you will find BNP and pro-BNP high. And these biomarkers are very important for risk stratification of such patients and for further management steps later on. And the evidence behind testing the biomarkers in such patients, there is one of the meta-analysis done for 20 studies. They found that elevated troponins is associated with 5-fold increase in the mortality. And also in a meta-analysis of 16 studies, they found that BNP more than 100 is associated with 6-fold increased mortality. So combining 2 studies together increase the prognostic value, of course. What is about D-dimers? D-dimers is commonly used in a patient who is suspected to have pulmonary embolism. And you know, guys, that it has a very high sensitivity of 95% and quite low specificity, 40 to 68%. It has a good negative predictive value to rule out the pulmonary embolism, but you should be cautious, should be correlated with the clinical probability. In the guidelines, they mentioned that it is a good negative predictive value in patients with low pre-test probability. That's why you have to do the clinical probability at the bedside for your patient. Also, one of the most important points to consider when you are interpreting the D-dimers, that the type of test matters. In order to have a good sensitivity for the D-dimers, it should be done by quantitative ELISA to be dependable in rolling out the pulmonary embolism. Also, that D-dimer level and the cutoff value is dependent on the age above 50. Above 50, the cutoff value is decreasing up to 10%, the sensitivity in the patients at the age of 80. So you can just calculate your cut. Before in the guidelines, they mentioned the cutoff value of 500 for the D-dimers. Below 500, you can rule out pulmonary embolism. But in the latest guidelines, they mentioned that you have to correlate your cutoff value with the age of the patient. For example, if you have a a patient who has age of 70-year-old, multiply this times 10 microgram per liter. So the cutoff value for this patient is 700 microgram per liter. To use it with low clinical probability, you can rule out pulmonary embolism. It is also recommended not to use D-dimers for ICU patients, especially who have a high risk probability, high risk pulmonary embolism. If you have a patient who has high clinical probability for pulmonary embolism, forget about D-dimers. It is unsafe to depend on D-dimers to rule out pulmonary embolism in such patients. Also, in terms of predictors for mortality, the imaging studies, and on the top of the imaging studies here is the echo, and always we have an argument with the cardiologist that my patient in need for echo, he is hemodynamically unstable or even stable, but I want to rule out RV dysfunction in order to risk stratifying. So echo is very important for the prognosis and for diagnosis and for risk stratification. So the evidence behind the use of echo in pulmonary embolism patients is one of the interesting meta-analysis that is done for included more than 12 studies and recruited more than 3,200 patients who are hemodynamically stable. But they studied the RV dysfunction. So they found that in the patients who have RV dysfunction, the mortality almost double the patients who have no RV dysfunction, 13.7% versus 6.5%. See how the echo is valuable at the bedside. In another meta-analysis of 239 patients included from 4 studies, they found that if you have a hemodynamically stable patient with pulmonary embolism and the RV function is normal, the mortality is almost 0. So echo is very important for risk stratification. If you have a patient who is shocked, you might consider reperfusion therapy. But if the patient is not shocked and you have done the echo and the echo showed RV dysfunction and he has elevated troponin, so this patient has intermediate risk pulmonary embolism, which is intermediate high risk pulmonary embolism. This is a submassive pulmonary embolism, and this patient might be considered for reperfusion therapy the same as the patient who has high risk pulmonary embolism. But if you have a normal RV function, so this patient might be considered for therapeutic anticoagulation only. So what are the findings you might encounter in the echocardiography? In all the views, you can have some information, like the parasternal long axis view, you can see the dilated RV. In the apical forehead chamber view, at the base of the RV LV ratio more than 1, and the McConnell sign, hyperdynamic apex with hypokinetic free wall of the RV, or in the parasternal short axis view, you can see flattened septum and D-shaped septum. In the subcostal view, you can see the dilated non-collapsible IVC. And also in the one of the short axis view, the Doppler study of the pulmonary flow, you can find the 60-60 sign, which is the coexistence of acceleration time of pulmonary ejection below 60, in addition to the peak systolic gradient as a tricuspid valve and the apical forehead chamber view, which is below 60. And also one of the interesting studies to date studied the echocardiographic findings for a patient who already diagnosed as pulmonary embolism by CT pulmonary angio. They found the systolic notch here in the Doppler study is very sensitive and specific for diagnosing pulmonary embolism. And you might find also a thrombus in the RV or the RA, and you can measure the TAPC by the M mode, which will be below 60 millimeter of mercury or 1.6 centimeter. This is denoting RV dysfunction. And this is a study for the 60-60 sign, and the McConnell signs are reliable signs for pulmonary embolism, but not sensitive signs for acute pulmonary embolism. This means if you haven't seen McConnell sign and 66 sign, this means that it doesn't mean that pulmonary embolism is ruled out. So in terms of the management, of course, we will talk a bit about the airway breathing and the hemodynamic support by fluids, pressors, and we'll talk about the anticoagulation, thrombolysis, and surgical management, and of course, the IVC filter. For the ABCs, starting with the airway and breathing, as we have mentioned that most of the patients are not hypoxemic and they have a good BO2 above 80, so rarely they will need a high flow oxygen, except if it is a high risk pulmonary embolism or intermediate high risk pulmonary embolism. So during the induction time and post pressure ventilation, that is very crucial time for those patients because the RV is compromised, and with post pressure ventilation, it is gonna be compromised more. So please be very careful during the intubation and mechanically ventilating such patients because they might arrest only during the intubation and start initiation of post pressure ventilation. They don't need high beep and they don't need high tidal volume. You can use 6 ml per kg, that's more than enough. Keep your target plateau below 30 centimeters of water, and always use anesthetic medications during the induction, which cannot compromise the hemodynamics. Also in the guidelines, to just avoid this situation, you can use high frequency nasal cannula and trial of NIV if it is not contraindicated, of course. Regarding the hemodynamic support fluids, yes, we can give some fluids cautiously, and judicious fluid management is very crucial in such patients because you might compromise the RV more with excessive fluids because there is ventricular interdependence. As we have mentioned, that the interventricular septum will be shifted to the other side, which decreasing the left ventricular endosteric volume, compromising the cardiac output and shock state more. And the first choice for the vasopressors is the norepinephrine. You might consider dobutamine if the blood pressure is fine, but you have low cardiac index and hypoperfusion state. You might consider dobutamine as well. There is reports about levosimendan. It improves the cardiac or the RV pulmonary coupling. So levosimendan can be considered. Also, there is some reports using the nitric oxide and the ECMO. ECMO, you know that ECMO is a bridge for something. So if your facility has ECMO and you can consider ECMO in a patient who has refractory shock or BA-related cardiac arrest, refractory hypoxemia, but it is a bridge to reperfusion therapy, you should consider surgical embolectomy or catheter-directed therapy in such patients. Otherwise, no RCTs to support the ECMO so far. In terms of anticoagulations, if you have a high clinical suspicion of pulmonary embolism, that is a high or intermediate clinical probability, you should start anticoagulation upfront immediately, and this is a high level of evidence. Of course, still the recommendation is to use unfractionated heparin IV infusion as per your local protocol if the patient is hemodynamically unstable or you have a high risk of bleeding or renal dysfunction with creatinine clearance below 30. For intermediate and low risk, the recommendation with high level of evidence is to use the low molecular weight heparin or fendabarnex over unfractionated heparin. What is about NOACs? Novel oral anticoagulants like rivaroxaban, apixaban, dabigatran can be used to replace the vitamin K antagonist, which is commonly used, the warfarin, instead, and it has no inferiority in the studies to warfarin. So it is highly recommended to be used, but it's contraindicated to be used during pregnancy, lactation, or renal impairment. Thrombolysis has its pros and cons, and the pros, it has a short-term improved RV function and also improvement of the pulmonary perfusion. In one of the meta-analysis, there is improvement in the mortality and short-term recurrence of pulmonary embolism. But the cons on the other side, there is increased risk of bleeding and also no clear evidence of long-term improvement in the RV function. So what is in the guidelines? There is a lot of debate in this point. Does it improve the mortality or not? But always go to the guidelines. All the guidelines with different levels of evidence, almost near to each other in the level of evidence, it is supporting to give the thrombolytic therapy for the patient who has massive pulmonary embolism or high-risk pulmonary embolism. That is the patient who has obstructive shock and no contraindication to thrombolysis. Also from the American Heart Association, almost the same, and from the European Society of Cardiology guidelines, the latest version, the level of evidence is higher than the others. Thrombolytic therapy is recommended, full stop. So what is about the intermediate risk? We talk about the massive or high risk pulmonary embolism, and of course, low risk or non-massive. This is out of our scope. This is not an ICU patient in a way. So what is the intermediate risk pulmonary embolism? If you are talking about something in the gray zone, which is intermediate, always there is controversy and debate. Somebody will say, I'm gonna thrombolize this patient. The other one, he will say, no, I will not thrombolize such patients. Only I will therapeutically anticoagulate him, and both of them are right. Depending on what? Depending on the situation, the clinical presentation of the patient, the risk of bleeding, the age of the patient, the comorbidities, and so. So one of the evidence behind the thrombolytic therapy and intermediate risk pulmonary embolism is the PITHU trial. This is the biggest trial to date. It is a very big RCT, studied the thrombolytic therapy in patients with intermediate risk pulmonary embolism. They randomized more than 1,000 patients for 5 years in 13 countries, multi-center international one, who are hemodynamically stable, but they have RV dysfunction and high troponin. So by definition, this is intermediate high risk pulmonary embolism. One arm received the heparin plus placebo, and the other received the heparin plus thrombolytic therapy. In this trial, it was tinctiplase. The risk of bleeding was much higher in such group, received the thrombolysis 11.5% versus 2.4% only on the other arm. But all-cause mortality and the hemodynamic decompensation, which was of the RV, which was the primary outcome in this trial, was 2.6% versus 5.6% in favor of thrombolysis. And at 30 days, there was no significant difference in the mortality. So they concluded that in patients with intermediate risk pulmonary embolism, thrombolysis can be considered and associated with improved hemodynamic decompensation, but there is increased risk of bleeding. There is another meta-analysis of 16 trials with almost the same results. So what is in the guidelines? In the European Society of Cardiology latest version of guidelines, you have to consider rescue thrombolytic therapy in patients with hemodynamic deterioration on anticoagulation treatment, and the level of evidence is quite good. So you admitted the patient with intermediate high-risk pulmonary embolism to the ICU, and those kinds of patients, guys, should be admitted to the ICU for close monitoring of observation, because he might deteriorate very fast in terms of oxygenation, respiratory parameters, or hemodynamics. In spite of therapeutically anticoagulating these patients, he deteriorated more, so you should consider thrombolytic therapy. What if the thrombolytic therapy is contraindicated or the patient has high risk of bleeding? You might consider some alternatives, which are the catheter-directed therapy. And the catheter-directed therapy is not only catheter-directed embolectomy, it is catheter-directed fragmentation of the thrombus, catheter-directed thrombolysis, and catheter-directed embolectomy. And also surgical embolectomy if you have the facility and expertise to do these alternatives, you might use it, and it has 87% rate of success. So no RCTs to date to support this, and all the data extrapolated from the case series and registries. But there is one interesting RCT to date published in the American Heart Association Journal regarding the use of catheter-directed thrombolytic therapy, and they use the ultrasound-assisted cardiac catheter-directed thrombolysis for intermediate risk pulmonary embolism. And they use the catheter for fragmentation, ultrasound fragmentation of the catheter in the pulmonary artery, and they left the catheter in situ in the pulmonary artery, and they give the RTBA through the catheter directly to the thrombus. And usually in such scenarios, the dose is given is very low dose. It's 10 to 20 milligram only of RTB compared to the 100 milligram of RTB. So the risk of bleeding is very minimal, but it needs, again, the facility and expertise. In this study, it is associated with improvement of the RV function at 24 hours without increasing risk of bleeding. So let's sum up in order not to be confused the clinical scenario between the different guidelines. If the patient has massive BE, all the guidelines with thrombolysis, with systemic thrombolysis, with almost the same level of evidence. Systemic thrombolysis for all submassive BE, no in all guidelines. Systemic thrombolysis for intermediate high risk pulmonary embolism, yes, 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 but in selected patients. Again, you have to select your patient. The patient who has hemodynamic instability in spite of adequate therapeutic anticoagulation, or if the patient is worsening in terms of hemodynamics, or worsening respiratory insufficiency, or severe RV dysfunction, massive or major myocardial necrosis. So you have to consider the reperfusion therapy in such patients, either to thrombolyze him or to use a catheter-directed therapy instead. Catheter-directed therapy may be used, yes, especially for such patients who have contraindication to thrombolytic therapy, or the patient who has persistent shock following thrombolytic therapy, that is the failed thrombolytic therapy. You can consider the catheter-directed therapy. For the IVC filters, the evidence behind the use of IVC filters is the PREBIC trials, PREBIC 1 and PREBIC 1 follow-up at 8 years, and PREBIC 2 trials. And IVC filters should be considered in a patient with acute pulmonary embolism who has absolute contraindication to anticoagulation, or if your patient has recurrent pulmonary embolism in spite of therapeutic levels of anticoagulation, those are the patients to consider IVC filter, but routine use of IVC filter is not recommended. So regarding COVID-19 related venous thromboembolism, and one of the fascinating pathophysiological mechanisms for thromboembolic manifestations in such patients published in one of the studies, that you know, guys, that SARS-CoV-2 targeting the ACE2 receptors, and ACE2 receptors is the receptors for angiotensin 2, which later on converted to angiotensin 1-7, which enhances the release of nitric oxide from the vascular endothelium. And nitric oxide is, of course, it's vasodilator and prevents platelet aggregation. So it doesn't work with that. And also angiotensin 2 is vasoconstrictor together with pouring of von Willebrand factor and deficiency of ADAM13. This might be one of the pathophysiology behind the COVID-19 related thromboembolism. Also, in one of the reviews published to date about characteristics of COVID-19 coagulopathy, they found that most of out of hospital sudden death related to thromboembolic events, specifically the pulmonary embolism. And this is the first autopsy series from New Orleans regarding the pulmonary and the cardiac pathology in COVID-19. You can see here the lungs are very congested, and here the heart, the RV is dilated with flattened septum, and there is multiple microthrombi over there in the pulmonary vessels, as you can see these white arrows. Another study that high risk of thrombosis in patients with severe SARS-CoV-2 infection, they found in 150 patients with COVID-19 related ER, they found that 64% of them developed the thromboembolic events, specifically the pulmonary embolism. That's why the hospitals incorporated in their protocol of management the thromboprophylaxis, and some protocols recommended to use the therapeutic anticoagulation. One from the American eminent hospitals is the Mass General Hospital. They stated that you can consider pulmonary embolism in case of marked increase or rising of D-dimers from prior levels and acute worsening of oxygenation hemodynamics, which is not consistent with worsening related to COVID-19. So they recommend also to use a bedside tools if you have a concern in terms of staph exposure, or your patient is unstable to go to the CT angio. So you can use the Doppler study of the lower limbs to check if there is DVT or not, so you are safe to therapeutically anticoagulate your patient, or to use an echo to see the RV strain, which is unexplained by ERDS. So you might find the thrombus also in the RV or RE. These are the patients you can consider therapeutic anticoagulation. And one of the interesting protocols also from Imperial College for the thromboprophylaxis and therapeutic anticoagulation based on the patient's body weight and D-dimer level, and the D-dimer level ranging from 1,000 to 3,000. So you can consider PD dose of enoxaparin or even therapeutic doses. And this algorithm adopted from the European Society of Cardiology latest guidelines that the patients with acute pulmonary embolism, if you have the suspicion, you should start immediately anticoagulation unless it's contraindicated. So if the patient is hemodynamically unstable with signs of hypoperfusion, this is a high-risk patient, and you should consider reperfusion therapy and hemodynamic support. But if the patient is hemodynamically stable, you should do risk stratification based on the simplified pulmonary embolism severity index, and check the RV dysfunction by transthoracic echo, or even in the CT you might find the RV dilatation, which is suggestive of RV pressure or overload. If you neither one of them is positive, so this is a low risk pulmonary embolism, his disposition will be in the floor or the ward. But if the patient has one or two of both plus RV dysfunction and elevated troponin, this is the intermediate high risk pulmonary embolism, and you can see almost he needs also consider admission of this patient to ICU. He needs close monitoring and observation for further deterioration, and you can consider rescue reperfusion therapy. Otherwise, he is intermediate low risk pulmonary embolism, and you can consider only therapeutic anticoagulation. So let's take the home message that high level of clinical suspicion is very important, as presenting signs and symptoms are variable, and the diagnosis best made by combination of imaging study, clinical probability as well. Prognostic features of for increased mortality includes PNP, troponin, and RV size and function. And the guidelines recommend thrombolysis for shocked patients. Patients with submassive or intermediate risk pulmonary embolism should be closely monitored further for deterioration and possible reperfusion therapy. you can consider IVC filter in patients with absolute contraindication to anticoagulation. And I cannot finish this lecture without highlighting the PERT, Pulmonary Embolism Response Team, because you guys know that there is some situations which are controversial and it is case by case scenario. That's why in the first time in the guidelines, they recommend to set up the Pulmonary Embolism Response Team, which is a multidisciplinary team that comes out with or comes up with a consensus decision regarding the reperfusion therapy, the disposition of the patients, and specifically for the patients with intermediate high-risk pulmonary embolism. And thank you. I'm ready to answer any questions.
Oh, Dr. Tolu, Prof. Tolu. Oh, good evening. Just mute yourself. Excellent.
Okay.
Fantastic.
So, wow, Dr. Issa, that is absolutely outstanding presentation.
Thank you.
For some of us not working in the intensive care at the moment, I tell you, you have educated us in the very short 45 minutes you have presented. That is absolutely outstanding. I say big congratulations to you. Then aside from that, I want to say big congratulations for putting in so much effort. World class. Number one, they were asking, why not use fondaparinux instead of the other agents? And if you're going to be using fondaparinux, what are the advantages over other agents? And one of the attendees asked a question, is there levosimendan, is it available in Egypt?
Okay, regarding fondaparinux, it is at the same level of evidence with the low molecular weight heparin. So you can use either low molecular weight heparin or fondaparinux. And the advantage of fondaparinux, it is low risk of heparin-induced thrombosis. Levosimendan, I'm not sure. Since a long time, I'm not working in Egypt, so I'm not sure it is available in Egypt or not.
Okay, thank you for that. Now, the other question, I'm sure most of the people that have listened to you, they work in the field of anesthesia. I have a lot of questions, talking about the use of IVC filters.
Yeah.
Now, one person asked a question. Can you use IVC filter as a prophylactic measure prior to surgery?
For what? Based on the patient, actually. The recommendation is not to routinely use the IVC filter. So IVC filter is recommended for the patients who has pulmonary embolism and therapeutically anticoagulated and there is recurrence of pulmonary embolism, or the patient who has contraindication to therapeutic anticoagulation. This is the patient you can consider. Sometimes, and I think Dr. Saad might share us in this answer from his expertise as an anesthesiologist. But sometimes it is used pre-operatively for the patients who has, for example, DVT and is going or high risk for pulmonary embolism and is going to the theater, and you cannot therapeutically anticoagulate those patients. So, Dr. Saad.
Certainly, we use them very frequently. If the patient is high risk for pulmonary embolism, we send them immediately before surgery to the interventional radiology and the insert IVC filter and the complete the surgery, just to avoid giving them anticoagulant prior to the operation immediately.
For the risk of bleeding, very operative risk of bleeding. Yeah.
Okay, thank you for that. Now, another question for you, sir. It says, can IVC filter be used prophylactically for patients that have active deep vein thrombosis?
For active DVT thrombosis.
Yeah.
And he is on therapeutic anticoagulation or not?
He's not. But they're wondering, can you prophylactically put an IVC filter for somebody that is suspected?
No recommendation in this point. No
Okay.
recommendation to the best of my knowledge regarding the use of prophylactic IVC filter for such patients.
Beautiful. Now, one before the last question. Somebody has just asked in the audience, if a patient has pulmonary embolism, what is the recommended guideline? What medication do you start? Do you start them at the same time on warfarin, on hepain? And how long do they stay on the warfarin for?
Okay, we have mentioned that during the presentation that if you have the high clinical suspicion that is a patient with intermediate or high risk BE, you should consider therapeutic anticoagulation, and it is recommended to use unfractionated heparin based on the local protocol available in your facility. You start unfractionated heparin and you measure BTTQ 6 hours to the therapeutic target. And also, in order to combine the vitamin K antagonist, which is commonly used warfarin, you should reach the target of INR 2 to 3 in 2 consecutive days before discontinuing heparin and continue on the vitamin K antagonist. But nowadays, because of non-inferiority of the NOACs, rivaroxaban, ibixaban, dabigatran, non-inferior to vitamin K antagonist, is recommended to be used instead of this combination from the start. I hope I answered this.
Yeah, absolutely. Yeah. Now, finally, somebody just asked that one of their patients has pulmonary embolism and is going for a surgery. Do you advise a regional anesthesia or do you advise a general anesthesia for this patient?
He has pulmonary embolism.
Yes, and the patient is going for surgery. That if there's an opportunity to perform a regional technique as opposed to a general anesthesia, which one will you support?
I believe the decision will depend on what kind of therapy is receiving. Does the patient on therapeutic anticoagulant or vitamin K antagonist or NOACs? And it needs a multidisciplinary team approach, actually, between the anesthetist.
I may take over here, if you don't mind. Basically, if the patient has pulmonary embolism, he should not go for surgery. And if the patient is anticoagulated, if it is emergency, we stratify the risk factors and we advise the patient and advise the surgeon about the high risk factor for pulmonary embolism. If the patient is elective, his patient should be anticoagulated for at least minimum 3 to 6 months on oral anticoagulant or low molecular weight heparin or whatever protocol by the hematologist, and we reassess him again. I believe elective surgery should not be started before at minimum 3 to 6 months.
Fantastic. Okay, I think Dr. Aissa, one more time, thank you so much for this outstanding presentation.
Thank you.
Dr. Garazi as well. Thank you so much for, blowing our minds with your outstanding presentation. Finally, I want to thank Dr. Adel Ibrahim, Dr. Sadmadi for this amazing mega course you guys are organizing. Thank you so much. It is very reaching, and we thank you so much for all the effort you are putting into this. And for all the people listening to us as well, we hope to see you again very soon, and very shortly.
Very soon, Prof. TOLU, and tonight I'm a little bit announcing tomorrow we have another great night tomorrow. We have here now on board Prof. Abdulazim Dawlatli, and he's going to give us tomorrow an outstanding his experience as a great researcher from Saudi Arabia and the international speaker. He is going to talk to us about your paper in the view of editor, reviewer, and reader. I would like to welcome tomorrow at the same time, 8 o'clock in the mega online course, Prof. Abdulazim Dawlatli, and more than welcome tomorrow, and we can't wait for him. I would like to advise everybody to sign in the Zoom webinar because it will be a great night tomorrow at 8 o'clock in the mega online course. Thank you very much for attending tonight. And we are honored tonight as well by our great Professor Samir Ansari, and he is attending the whole session and praises the 2 lectures tonight, and I'm so humbled about his attendance tonight. Thank you very much, everybody, tonight. Dr. Sahar Marzouk from the MEGA Online course, and thank you very much.
Thank you.
Thank you.
Thank you,
Thank
everybody.
you.
Thank you.